Follow the page on Facebook, Instagram, YouTube and Telegram. Thank you, doctors.
Hi, I'm Rui Pereira da Costa, organizer of this World Online Congress of Endodontics. What a tremendous ride it's been, isn't it? I'm sure you agree. So here we are at the end of day 4 of this Endo Masters 2015. The amount of endoscience and clinical updates is huge. I'm sure you don't see many congresses like this, do you? Well, I reserved a very special lecture to wrap up the day. Let me present you Carlos Murgel from Brazil. Carlos has always been a big reference for me in endodontics, so it is with a special honor that I introduce his lecture. Carlos graduated from the University of São Paulo, Brazil, and he did a residency in endodontics at the University of Iowa in the USA and the doctorate in endodontics at the University of Campinas in Brazil. Carlos Murgel is a pioneer in microdentistry teaching with the implementation of the first microscope training center in Brazil and South America at the University of Campinas in 1995. He is professor of microdentistry at the Pacific Endodontic Research Foundation in San Diego, California, author of several scientific articles, chapters, and a book in microdentistry, and an international speaker. Carlos will show us today how combining the technologies of cone beam computerized tomography and the surgical microscope leads to a tremendous improvement in the management of complex cases. I'm truly glad you're not missing this lecture. See you tomorrow. Take care.
Hello everybody. I'm here to participate at the International Endomaster 2015 International Congress. This is an incredible adventure, if I may say this, that Rui and his outstanding team put together to share knowledge throughout the world. The last count that I saw, we have 104 countries participating. This is amazing, and I'm sure this will make history. My talk today is going to be about contemporary endodontics, microscope and CBCT maximizing management of complex cases. So before we start, I will remove my image from the screen since I'm not a Hollywood star and I'm very uncomfortable lecturing for a computer, and we will focus on my presentation. I hope you guys enjoy and take some out of this. I'm doing this to share my passion for endodontics and for new technologies, and to expand the perception of endodontics outside the root canal space. Thank you for watching me. Now we will start our lecture, and the program for today is going to be about magnification, CBCT, small valve CBCT, and the management of complex clinical cases. We will discuss these topics and trying to put some different perspective to you. Magnification. To us, magnification is the key of a quality center practice, regardless of the specialty that you may practice. Magnification is mandatory for everybody that wants to practice in the highest level as possible. We have many forms of magnification. We have loupes and we have microscopes. Magnification is really important because it will enhance your fine motor skills, as demonstrated by this article published at GOE 2009. You can increase your overall fine motor skills by 17.5% with 2.5x loupes and by 57.7% with 8x operating microscope when compared with naked eyes. So think about this for a second. What this research is showing to us is that you will increase your fine motor skills if you see more. You will get more refined movements, more precise movements when you see more. Think about this for a second. The other question that a lot of people ask me is that, oh, okay, but if I use the microscope or the loops, I will be slower. This is not true. The problem is, if you don't know how to work with the operating microscope or with loops, yes, you are going to be slower. But once you master the technique, once you go through the learning curve, then you will be actually faster. So this research is a keystone to us to show that by seeing more, you are going to have more fine motor skills. And this is what we need. We have a profession that needs a lot of fine motor skills. And in order to do that, in order to develop more fine motor skills, you need to see more. You need to have magnification to assist you to do that. The philosophy that we practice and teach was developed by Dr. Gary Carr, and I had the pleasure to publish one article with him at Dental Clinic of North America in 2010. You are very welcome to look this article. In this particular article, we describe our philosophy and why we work this way. The operating microscope is a technology that you cannot buy the equipment and expect to be proficient the way you were before, because you need to change a lot of your thinking to take advantage of this technology. So, a lot of endodontists in the past, they used to say that they can do much of their work blindfolded, simply because there is nothing to see. The truth is that there is a great deal to see with the right tools. So I hope at the end of this presentation, you can really value magnification and see how important this is to endodontics. In order to take advantage of this technology, you need to develop a set of skills, a set of ergonomic skills to do only what you are trained to do. Root canals, dentistry. All the accessory work is going to be done by the assistant, and you need to be focused 100% of the time at the operative field. You should not leave the microscope or the operative field to do other things that are not related to your work. You need to develop a lot of the ergonomic skills. You need to prepare your office to receive this technology, and you need to be ready to change. If you don't want to change, it's going to be very hard to incorporate this technology as any other technology. And if you think for a second, we have been working like this. This is very, very bad for your health. This is bad for your eyes. This is bad for your back. This is bad for your level of contamination. So the real question is why we work this way. Who said that we should work this way? The only person that's going to give permission for you to work this way is yourself. If you don't like to work this way, stop working and try to tell yourself that from now on you're going to sit straight and you're going to work this way. If you use loops, if you use microscopes, or if you don't use anything, don't let yourself work in the old way. This will harm your body, destroy your profession, and will short your career. Now, the way we work may be a dream for a lot of people, but it's a very, very easy way to work, very productive, and very simple way. The only thing that you need to do is to learn the principles that were described in the article that I showed before. Once you work this way, it's very organized, it's very easy. You eliminate a lot of the stress, a lot of the frustration. And as you can see in this image, the assistant also has her own operating microscope, because we believe that both of the team players, doctors and assistants, they need to see the same operative field that must be seen during the work. We don't think that the assistant should be alienated from our work, trying to see in some very impossible areas that she cannot see what we do. We believe that she must work with the operating microscope also, that she must use arm support, that she must have an ergonomic setup so she can be healthy and productive throughout her entire career. This is not a dream. This is the way we work, and many colleagues work this way also. So, if you have loops, if you have the right pair of loops, you can work the same way too. The only thing that you need to do when you're going to buy a pair of loops, you need to find your focal distance. And to find a focal distance, you need to sit straight, position your patient the way you work, and measure from the highest part of your nose until the patient mouth. This distance is going to be your focal distance. So when you buy a pair of loops, I'm talking about mainly prismatic loops, you are going to tell the vendor, you're going to tell them, look, I need a pair of loops of 250 millimeters of focal distance. I want a pair of loops of 300 millimeters of focal distance. And this will allow you to work at this position. This is a fixed position, and these loops will not allow you to be closer or further from your patient. So with a simple loop, pair of loops, or a microscope, you can eliminate a lot of the ergonomic problems that we have been facing for centuries. To us, magnification is excellence. When we do a case like this, we are going to do a root canal retreatment. We are so used to be focused on the radiograph that we don't see what we really need to see. So I want you to follow this case and to see through my eyes. So all my cases are done under the operating microscope. All my pictures are taken under the operating microscope, and it is a very easy and effective way of work. So when you see at this magnification level, you can see that tooth number 12 at the international notation, or tooth number 7 at the American notation. There are some problems at the distal margin, right? If I increase the magnification, I have more details, and we can notice that the crown is loose. I can see the marginal contour, I can see the soft tissue. I can show this image that we are used to see, a radiograph with a file, a rubber dam, or I can start to see in a different way. I can look now for the first time inside the root canal system and see the obturation done, and see how well this gutta percha is adapted. I can see with more magnification if the walls are clean, how it is my obturating material. So what I want to show to you is how to look to details, how to see different now that we have magnification. So I can see the rubber dam, place it, I can see that the clamp is not touching the soft tissue, and I will do a post and core reconstruction just to exemplify what magnification can bring to you. So we will use a plastic crown to build the build-up. I'm trying that. I'm trying to see the marginal adaptation of this plastic crown. I will try the post, the fiber post. You can also notice how well the rubber dam is invaginated at the sulcus. I can start to see now the etching procedure, and you're going to be amazed to see how difficult it is to get this etch inside the root canal, because you can see a lot of bubbles coming out. Usually due to its high superficial tension, it will form a bubble at the beginning of the root canal. So you need to use a small needle with a very deep penetration. And I will try to clean this root canal with our conventional air-water syringe. And what's going to happen is that I will not be able to remove the acid from the inside of the root canal. This is a common occurrence, but because we don't know that this is happening. So what's going to happen is that you're going to have a failure at your bonding. And then you're going to say, well, bonding doesn't work in endodontics. In reality, we need to downsize our equipment, and we need to have a special air-water syringe called stropical, where you can put whatever needle size diameter you want to get this water and air deep down inside the root canal. Now you can see that the root canal is clean, but it is humid. I will dry with a paper point, and I will apply my bonding. You also can notice now that we have an orange filter to prevent polymerization. But if you realize about what's going on in this image, you're going to see that the smallest microbrush is not small enough to enter inside the root canal. You also are going to see that I have a bubble, a big bubble, besides those 3 small bubbles, that it is preventing the bonding to get inside the root canal system due to its elevated superficial tension. So in order to get this material down to the root canal, I need to break this bubble with a paper point to get all my bonding inside the root canal. I also can do the polymerization. We usually use dual cure materials because we know that the light won't get down to the depth of the root canal. And I can see how the gutta percha, it is sealed with the bonding agent. Now I will inject the resin material. We usually use a Luxacort material with a syringe, mainly centrics, trying to avoid bubbles. And I will place the composite inside the root canal and the fiber post. I will polymerize, then I will cut the post. Some people like to cut the post before, others after. I want you to think about this case. It is almost 12, 13 years old. Now we place the crown to see its adaptation, the size of the post, and I will start to build up with composite resin, do all my bonding procedures again, and I will start to put the resin and put the plastic crown, polymerize, and remove the crown and the excess. So now I have a tooth-like build-up. We have no intention to have interproximal contact with this kind of a build-up. This is not a tooth. This is just a tooth-like build-up. But the most important thing here is to remove any excess of the margins, is to send this patient to the referral with a clean margin where the referral is going to have an easy time to prep this tooth to do a temporary crown. So see how different levels of magnification can show to you different levels of your work, so you know what you are doing. So start from now thinking about clinical images and not only radiographs. Okay? Now, the next topic that we will cover before going to the clinical cases is the small FOV CBCT in endodontics. This is a very, very nice topic. And before you start to use any technology, you need to do the W's test. So why this is important to me? Why use CBCT clinically? What is this technology about? What should you know about it? What is this technology good for? When should I use it clinically? Why the report isn't good enough? What machine should I use? When should I use incorporated? So, which kind of machine is this? What is this technology about? This technology is a cone-shaped X-ray beam and the detector, or flat panel, as you can see on the right side, rotate once around the patient and captures a cylindrical volume of data, field of view. So this is an X-ray machine that will rotate 360 degrees. Some machines now rotate only 180 degrees around the patient and will create a cylindrical volume of data. Okay? The size of view, FOV, is variable. Larger volume CBCT scanners being capable of capturing the entire maxillofacial skeleton. Some CBCT scanners also allow the height of the cylindrical field of view to be adjusted to capture only the maxilla or the mandible. So the field of view is going to be variable. The larger the field of view, the higher the radiation the patient is going to take, and the lower the resolution. Lower radiation than conventional computed tomography. When you compare the dental tomography to the medical tomography, our tomographers are much more lower radiation when compared to the medical ones. We are going to have a three-dimensional volume of data. So, we have different kinds of machines, and they are not equal. Even though they are called CBCT, they are not equal because the FOV, the focal field of view, it is different. There are different machines concerning the field of view. Large FOV units need larger X-ray exposures. Large FOV units produce large areas scanned, consequently, more legal diagnostic responsibilities. And large FOV units produce lower spatial resolution, slice thickness images. So, if you have a machine that can take mandible, maxilla, and some part of the orbits, the resolution is going to be lower and the amount of X-ray that the patient is going to be exposed is going to be larger. On the other hand, if you have a machine with a small field of view, you're going to have a smaller area, lower radiation, and higher resolution. This is really important because for endodontics, we want to use the machine with the smaller field of view as possible and the lower radiation as possible. So different FOV size can take you from the medical on your left image to the dental with a smaller field of view at the center of the image. On the right side of the image you have a machine that will take mandible and maxillum at the same time. So it depends on what you want to do, you need to select your machine. If you are doing endo, go for the smaller field of view machines. If you are doing implants, full mouth rehabilitations, you can work with larger FOV machines. So the other thing that you need to know it is that this technology is computer dependent. You must understand this. You also need a robust backup plan because all the data that is going to be generated is going to be digital. Our units, you need to learn how to play with their software. And they have a similar layout. Usually they have 4 windows with 3 different planes and with a reconstruction image of the volume and the menu tools. There are 3 different slice planes to work with: axial, sagittal, and coronal. As you can see in this image, you have the first image clockwise is the sagittal plane, second it is the reconstruction, third it is the sagittal plane, and fourth it is the coronal plane. This is a different software from a different company, but showing the same 4 windows that we mentioned before. So you must understand that CBCT will produce 3D images, and there are 3 different slice planes to work with. Axial plane, first one, up and down. Sagittal, left and right. And coronal, front to back or back to front. So once you know the special slices, you need to be able to see the volume, to see the image on your left side and recognize that this image is going from the coronal part to the apical part of the maxilla. When you have a sagittal plane, you're going to see that this is coming from the middle of the maxilla to the buccal side of the teeth. When you look at the coronal, this image is coming from the posterior area to the anterior area of the maxilla. So one needs to understand and to know how to manipulate the volumes to be able to find the information available at the exam, at the volume, to be able to do your diagnosis in your treatment plan. So, with this in mind, I would like to share one of my first cases that I used the CBCT. This was a very straightforward case where I treated the second left upper premolar, and it was a necrotic case, a very straightforward case, small access, even though this case is very old. We have in our way of working, we have our philosophy of doing everything under the microscope, including measuring, filing, instrumenting, anything that we do under the microscope. In order to do that, you need to have the ergonomics down, and also you need to have a microscope with the lowest magnification you can afford or you can find in the larger field of view. If you have a microscope with a very high level of magnification in a small field of view, you won't be able to do this. So here we are placing the calcium hydroxide. Everything was fine. We proceed to do the obturation. 1 month later, yes, second molar still has a problem. Patient knows about it, but she doesn't want to do anything. We finish the root canal, small access, send the patient to the referral. Everything was fine. We were lucky. We had a lateral canal. I'm feeling good. At the recall, first year, lesion is healing. Everybody's happy. At the second year recall, I had a sinus tract over the first molar. And I thought, well, first molar became necrotic. Let's test. And the tooth was vital. So I did a radiograph with the GP, the contrast, and I saw that the gutta percha was going toward the tooth that I treated. So I said, okay, let's retreat second premolar. I removed the obturation. I placed calcium hydroxide for a month. Patient came back, still sinus tract present. Ooh. So I changed it again. Next month, still the same problem. At this time, I had a friend that had a radiologic center, and she said, you know, Carlos, I got the CBCT, the iCat machine. I don't know what to do with endodontics. Do you want to try? I said, yes. I have a patient that may be a nice patient. So I sent this patient to her, and if you compare the 2D digital X-ray with the CBCT axial plane, we are going to see the premolar at the buccal aspect of the buccal root of the first premolar. There is a lesion there that we didn't see at the radiograph. See the lesion? So I didn't see that lesion before. See at the coronal plane also you see the lesion clearly at the first premolar. So I was treating the wrong tooth. That's why I wasn't getting any good result. So with this simple exam, I was able to get a very good understanding why I wasn't getting a good result. If you see the reconstruction, you're going to see at the sagittal view that there is a suggestion of a lesion at the apical portion of the buccal root at the first premolar. So now with this information, I opened up the tooth, I tested, of course it wasn't vital, and I pushed calcium hydroxide. You can see a small line, and you can see that the calcium hydroxide went from the first premolar and left on the upper portion of the first molar. So the sinus tract was in a very odd position. After a month, sinus tract healed. We did the final obturation for both teeth, and finished in 1 year recall. So this case convinced me that we can use this technology to enhance the management of complex cases. So now I want to share with you some of our philosophy and some of our cases that we treat on a daily basis. We can use this technology to diagnose and make some really difficult treatment planning decisions. We can use this technology to see some trauma cases, to treat calcified canals, to treat missed canals, to treat complex anatomy, to management of root resorption, to do non-surgical root canal retreatment, to do non-surgical MB2 retreatment, very common in my practice, to do surgical root canal retreatment, to manage large lesions. But when I say large lesions, I'm talking about large lesions. We can plan complex restorative and implant cases. And we can start for the first time treating patients, not teeth. I think the most common errors, one of the most common errors that endodontics can do, it is to treat only teeth and not see the patient behind the teeth. So if you use this technology, the magnification, CBCT, you're going to start to see a lot of things that you need to study more, you need to go after a different knowledge that we used to have. So now for the first time, we need to think outside the box and stop thinking about making white lines. So let's start with this case. of the diagnosis and treatment plan. So, unfortunately, in Brazil, many endodontists still think that endo is an athletic specialty. So they want to do everything faster. They are not concerned about quality, about infection control, about treating patients. So this patient was treated 2 years ago by an endodontist that did all 4 teeth in a single appointment. We can see that the result, it isn't so good. Excessive root canal preparation, not good control of the apical area, and the end result, who knows about the conditions about isolation, I don't know. And the end result, it is that the patient has a large lesion, and now they send to me for apical surgery. So this is not a case for apical surgery in my practice. This is a case for conventional root canal treatment. But when you compare the X-ray image to the CBCT image, you're going to be amazed to see how different it is from what you see on the radiograph and what you can see with the CBCT. Now you can understand why surgery is not indicated. When you see the axial plane, you're going to see that this lesion is involving the mental foramen. This lesion is very large, and it would be almost impossible to do surgery here without of giving this patient as a gift paresthesia. So in this case, we presented to the patient with the possibility of retreating those root canals, but in a different way. Not doing a single appointment, a fast fix, but trying to minimize this infection and trying to give opportunity for the body to heal. How you do this? Plain old traditional endodontics. Root canal disinfection. What you use? Sodium hypochlorite, files, and intracanal medicament. What you need to do? You need to be patient. You need to place the material, wait a month, bring the patient back, and you start to see the healing. It's a magic. You can see the healing. You can see that the patient is free of their symptoms. You can see that the patient is healing. So why not take advantage of our knowledge and heal people instead of doing white lines? So we did this at the 5 months recall. The results were so good that we were able to finish the case. And you can see the massive amount of bone that was formed in the first 5 months. At the 11 months recall, we can see at the radiograph, very good healing, and at the CBCT, excellent healing also. We know that the bone will feel from the periphery to the center, and we know that this is a good sign of healing. In the 24 months, we can see a lot of bone. We can also see that the referral dentist still didn't restore the teeth with a restoration. Still, it is in my temporary restoration. But you can also notice that I do a sealing of the gutta percha, trying to minimize this kind of situation. So, a very complex case for some people, but can be a very simple and rewarding case if you have the knowledge and the technology to treat. Trauma cases. When you have a case like this, where this small little child had an impact on a door, and suddenly her front tooth number 11 or number 8, just disappeared. where is this tooth? When you take the scan, you can clearly see that this tooth invaded the nasal cavity by a large amount. And you can see in different planes how much it invaded and where it is. So now you can plan what to do. But our biggest problem was clinically, I had no crown. So how I am going to access this tooth to place my calcium hydroxide so the orthodontist can move this tooth? So now with the CBCT image, I can plan a different access using the one-to-one dimensional information that the CBCT will give to me. I can measure where I want to do my access. I can transfer this to the mouth, and I am able to perform a very conservative access using special instruments. I like to use the SSY kit for small access. I can make a very conservative access. I will not do surgery on this patient to expose the palatal surface of this tooth. I can irrigate this tooth. I can remove the pulpal tissue. I can do everything from this small access. So why not think outside the box by using magnification and CBCT? So I can do all the restorative, I can seal the restoration, I can do everything under the microscope, and the orthodontist was able to extrude this tooth, and I can continue replacing the calcium hydroxide. So this is a very simple case that was managed in a different way, where the patient didn't suffer, where the tooth was preserved. You can barely see any side of access on the left side, and I was able to do what I need to do. We also treat calcified canals. Cases like this, where this patient was going over many offices, and all the endodontists and the dentists, they would say, oh, well, I can't treat this tooth number 11 or 8, it is very calcified, I don't know what's going to happen, I may perforate it, you may be off with an implant. And with the CBCT, we can see that there is a canal there, we can see that there is a lesion at the apical portion of this root, and we can also see that there is a very large lateral canal at the buccal aspect of this root. Now that you have the CBCT, at the center, at the radiograph, you can see a small black dot there. But at the CBCT, this is so clear, and now we can measure the distance where this canal is going to start, and we can work at this canal. So let's see, some clinical images. We do all the testing under the microscope, probing, mechanical testing, thermal testing. We do the sinus tract analysis. Do we have a secretion? Do we have pus? Do we have epithelialized sinus tract? So we analyze everything. So the first thing that we do when we do a small access, a conservative access, we need to downsize our instruments. And for this purpose, the SSY kit, it is unbelievable. The size of the instruments are so small that you can barely see them. So on your right side at the red arrow, you can see our initial access, and you can see where the root canal is. Very easy, very precise. Once we find the canal, we are not making a canal, you start your instrumentation sequence. You slowly progress, and you can achieve your working length, and you can start now searching for that buccal canal that we saw at the CBCT. We know how deep it is. We can make a small bend on a small file, and we can get inside that canal. It's much better to clean mechanically than just imagine or hope that the irrigant will do the job. So now I can go inside that canal, and I usually go up to a 15 file. I use a reciprocating handpiece, M4 from Cybron, but there are other companies that use that. And I use this file just to reciprocate number 15. That's all what I want. Then we finish. We use calcium hydroxide, and we leave the patient for a month. Next month, I need to see sinus tract heal and no symptoms. If I don't have sinus tract healing and no symptoms, I will not finish the case. We will not finish any case if we don't have lack of symptoms and sinus tract healing. Takes time, yes, but I am sure that this patient is healing, that the infection was lower to allow the body to have a better healing. So once my criteria are obtained, I will proceed with the obturation. We use this roller developed by Scott Martin from the USA, where you can calibrate your master cones. Now he has one with half numbers, so 25, 27, 30, 32. It's a very, very nice and precise instrument. I cut my cone, I use the sealer, everything under the microscope. I want to see more, I want to be more conservative, more precise. So once the case is done, I can clean the chamber. In this case, I also did the bleaching with a very, very small access and a very conservative canal preparation. So we need to think about not over-enlarge the root canals, not weaken the root canals. I can have, missed canals. I can have a case like this, where the patient had a root canal done. Believe it or not, this was a root canal done and was paid to the endodontist. And now the patient has a sinus tract. Radiographically, there is no canal, but if you see at the CBCT, there is a canal. Clinically, we have a sinus tract and a discolored tooth. So the sinus tract was a little low, so I was thinking that may be a perforation. So I still had to explore that. So I want to examine the sinus tract. I want to see which kind of sinus tract is there, or I want to see what's the direction of the sinus tract. So we start the access. I remove some of the material. You can see dentin. You can see different color of dentin, and you can see composite resin. In such situation, we always use ultrasonic. I love to use it. Dr. Gary Carr's ultrasonic tips. His website is EIE2.com, and he has some incredible ultrasonic tips. So at this higher magnification, you can see where the root canal is. We know from the histology that the root canal will calcify from the periphery to the center. So you can see on the top portion of this image a white dentin, then a more dark dentin, and at the center a lighter dentin, and at the very center of this lighter dentin you can see a white spot. That's where the root canal is. So it didn't take me 5 minutes to find this canal. We did the root canal treatment, the regular calcium hydroxide, we bleached this tooth, and this is the final result. So, no sinus tract, no symptoms, maintaining the tooth, bleach the tooth only with sodium perborate and water. We restore the tooth with a fiber post, and composite resin. So this is how the patient is going to go to the referral, with the tooth fixed, ready, with aesthetics and function. This is how we like to treat our patients. We deal with complex anatomy. We have cases like this, which can be very simple or very complex, but my colleague was trying to access this tooth that was calcified due to his lack of CBCT or lack of willingness to send this patient to have a CBCT taken, and it was deviating from the canal. From the CBCT slices, you can see that it's very easy to see the canals. There is no doubt where the canals are. Very easy to treat, because now we know where the problem is located. So we start to see the case, and we see clinically, you have, the gutta percha was placed where the canal was created. You see the main canal, and you see an extra canal, that small bright dot, that it is an extra canal that we found. Usually in cases where I have small canals, calcified canals, I love to use the M4 or the reciprocating handpiece. When I can get the file down close to the working length, I use this system to lose the file, to make my life easier. I'm not talking about using a reciprocating file to instrument the canal. I'm just using this instrument with hand files to enlarge a little bit the coronal and middle portion of the canal. So we have the pre-op, we have the post-op with the anatomy, the two canals that I treated, the canal that the dentist created, and 1 year recall with the healing. So it can be very rewarding to treat cases like this, because nobody likes to do them, and you can have a success depending on your skill level and your technological level. So when I started using CBCT, I didn't know how to use this. So I had a case like this, upper left third molar, tooth number 16 or 28, and I would take a radiograph, try to get the best angle I could, and I would do the case. Very difficult. You see that the aperture of the patient's mouth is around 2 to 1.5 millimeters. Very difficult to work with, and I struggle all the way to do this root canal. But I never felt confident that I was doing a good job. I never knew the anatomy, and it was very difficult. But you see here that I use a small mirror, flexible mirror. There are a lot of ergonomic skills in order to do that under the microscope. So, because I have my CBCT unit at that time, I took a scan, and now it's very clear where the canals are. I have an extra palatal root. So I have buccal root, distal root, palatal root 1, and mesiopalatal root. Now I have to explain to the patient that the patient needs to go back to the chair, and I will find the extra root. Now you can see with the magnified image where the red arrow is, that I found the canal, and I will use all my ergonomics skills, use special pliers, applying the back of the mirror handle to engage the file. So you need to develop all the special ergonomic skills to work under the microscope in every area of the mouth. So the end result, I was able to treat the second palatal root, but because I didn't have my pre-operatorial CBCT, gave me a lot of trouble to figure this out, and I spent much more hours with the patient on the chair. So we will have cases like this, root resorption. I treated this case 14 years ago. At that time, to fill a resorption area like this, I would use calcium hydroxide, and that was it. So we were lucky that this process was stable, but 14 years, patient came back and we did the CBCT, and now I can have a very good idea of the defect, and I know the bone profile, and I will try to fix this. Now we have better technology. Now we have a better understanding of the problem. Now I can, for instance, diagnose the palatal area, and I can see a very, very small sinus tract. That for sure, I would not even look for that if I wasn't working with magnification. So when I opened up the tooth, I can see the calcium hydroxide, and I will clean that, and I will see the resorptive defect. So see how easy it is to work now that you can see more, and when you know what's going on, because you have a pre-op CBCT. You know the location, you know the size of the problem. So we did all the calcium hydroxide treatment, trying to get the sinus tract to heal. Here you can see a Dove gun carrier, placing calcium hydroxide or MTA, depends on the stage that you are working. And I would do all those calcium hydroxide treatments until I had the sinus tract heal. Sinus tract maybe look like it is healing, but if you look closer, it's still not perfect. So this is the level of attention that I want you guys to develop. I want you guys to see more, but in order to see more, you need to look more. So now, once the case is done, I can fill that defect with MTA, and I will restore that resorptive defect with composite resin, so I can send to my referral dentist sealed. So hopefully, 15 years from now, I will be able to have another lecture to present this case. We can do now non-surgical root canal treatment. And the first thing that I need to tell you is that we want to avoid surgery at all costs. This patient had 2 surgeries done already. But if you look at the restoration aspect of this tooth, you are going to see that it is very bad. The post is not adapted, the obturation is not good, so no wonder why the surgery is failing. So we will not do a surgery if we can retreat conventionally. We are going to use a technique here developed by our friend Terry Pankak that removes the apical retrograde from the root canal system. So first thing, we need to remove the post. And we use ultrasonic. You can use 1 or 2 to vibrate. And when this technique works, the post will come loose. If it doesn't work, you need to remove with other means. Now we are going to start to work toward the apical material that it is obturating. And you can clearly see that this material is all contaminated. So there is no way I will do an apical surgery in being able to clean this root canal. So I will remove this material and I will look at the apical portion of the tooth. And what we see there, we see a lot of mercury particles, mercury bubbles that are free at that region. So that is showing us that the surgery material that was applied, amalgam, wasn't manipulated the way it was supposed to be, and we still have free mercury at that time. So when you look down at the root canal, because it is a large tooth with a large apex, you can see at the red arrow the free mercury. You can see the material at the borders, maybe some cement, some sealer. So we will start following the technique developed by Terry Pankak, published at GOE, to remove from the root canal the obturation material apically. Takes time. This is not a fast track endo. And every time you place your post, you should seal the canal after the post to have your calcium hydroxide taking effect without of contamination. So we finish the case, we obturate with MTA. This is a 1 year recall and 2 years recall, where you can see that we still have some material left there. We were not able to remove everything. Even in surgery, sometimes you cannot remove all the material, but you see that the case is healing and the patient is asymptomatic. We also treat MB2s, this is very common in our practice. We have a case like this where an athlete endodontist finished his root canal, had a lot of surplus or a puff or whatever, but the patient still was symptomatic. So we scan the patient and you can clearly see at the red arrow that MD2 is still present. So think about this for a second. Patient just finished the root canal, spend money, and tooth is still hurting. What he thinks about endo? Now, what about if he goes or she goes to a dentist that tells her or him, look, root canals are not good. You need an implant. Let's extract this tooth and place an implant. Root canals are bad. But in reality, root canals are not bad. But the way we are doing is becoming a bad treatment because we are not doing what we should do. So we have a way of approaching MD2s. Usually you do the excess, never remove the gutta percha from the canal that you know that are treated. Use the ultrasonic blunt diamond tip, remove dentin, and then you can see at the end of the red arrow the MB2 there waiting to be treated. This MB2 was there all the time and it is full of contaminants. I always take a radiograph to make sure that I am at the MB2 and where the MB2 goes. I want to know if this is a separate foramen, if it joins the MB1, so I always take this radiograph. Once you do every time the same, you are consistent, you are more productive, and your assistant is able to follow you. So then we do the working length, we do the instrumentation, we do the M4 or the reciprocating trick to get the canal a little larger. So everything under the microscope, most of the times under the lower magnification, and we use a lot of pre-curved files. Our philosophy is not to over-enlarge the canal, to sterilize the canal. We want to touch the most parts of the canal, which, by the way, we know that we never touch all the walls of the root canal. There isn't any technique available today that can touch all the walls of the root canal during instrumentation. And if you check, if you really want to see, you are going to see that you still have a lot of material inside the root canal. And therefore, even though you may have mechanically obtained a working length or an apical diameter that you want, that you desire, this case is not ready to finish. So we place the medicament, we use calcium hydroxide, we irrigate, we dry the canals, and we apply the calcium hydroxide. We use kaolin from SS White. We like this material, and to us it's very easy to use. We also have some material from Ultradent, from other companies, but this is the material that we like to use. So once the patient is asymptomatic, the patient is symptom-free, I can obturate. You can see 4 canals, and at the 2 years recall, I can see that the dentist got a little carried away with the palatal post, almost reached the apex. So this is what we have for dessert, but if you follow your patients, you're going to see amazing things. The most important thing, patient is happy with endo now. Patient is asymptomatic. and the patient knows that endo can cure, instead of knowing that endo only will get their money, but the symptoms are going to stay. We can also do some surgical canal retreatment. So this case was retreated, a very complex anatomy at the palatal root, was filled with MTA. MTA wasn't too radiopaque at that time. At the control CBCT recall, we can see that the lesion is still present, and it is mainly at the palatal root. So we planned for surgery, a palatal root surgery. You can see two views of the CBCT. So you have the sagittal and the coronal view. So we knew that before we start doing surgery that we had no sinus involvement. So we will not go into the sinus. We will do a buccal window, a small window, using the mesial buccal root as the access point. And this is the palatal root after apicoectomy. See that we are doing a small and different flap with a different flap design, because we work under the microscope with magnification, so we can use different techniques. I'm sure this is a new concept for many of you, but microsurgery is a very predictable treatment when you perform it under its indications and using its techniques. So when we finish the case, this is the 1 week post-op suture removal. This is 1 year post-op. You can see the soft tissue. It's very good. Patient is still with temporary restoration. And this is the 2 years post-op. You can see the lamina dura at the palatal root, small area over the mesial buccal root. Patient is fine, asymptomatic, and we believe this is a small, maybe scar tissue on the top of the buccal root. So we can also manage large lesions. And because we use all the technologies that they are available now, we can see strange and very interesting cases like this. So patient came, was with this indication for apical surgery that was going to be performed at the hospital due to its large lesion, with a large buccal swelling, sinus tract, and horrible occlusion. So we did the CBCT examination, we did all the testing, we saw a large lesion with buccal involvement, but we saw that there was an opportunity for an endodontic treatment here, because we had tooth number 21 or number 9 that was non-vital, and unsatisfactory root canal treatments on tooth number 11, 12, or 7 and 8. So we talked to the patient and we said we are going to do the root canal. There was a lot of pus coming out of the central incisor. We did the regular root canal, the endodance, small files with precurved files, trying to reach the canals, irrigating, using the endoactivator, a very good product that I like to use on all my cases to agitate the liquid. And we would place calcium hydroxide post-op, 1 month, next visit 3 months, and we can clearly see that the bone is healing. So the patient is asymptomatic. There is no buccal swelling. Patient is very confident that we are going to be able to manage this case. So just analyzing, these images, you're going to see that the buccal area of this patient, the frenum area, was completely out of its normal shape. So at the pre-op, at the 1 month, and at the 3 months, you can see the difference. So now we have some bone at the buccal plate. Patient is very satisfied and is trusting our judgment for our treatment. So if you see the pre-op CBCT and the post-op with 3 months, you see that the bone is healing. You see that the buccal bone is forming. When you see at the pre-op and the post-op image at 5 months, you see that the buccal plate was completely regenerated and the bone is forming. In this case, nothing special was used besides sodium hypochlorite, calcium hydroxide, and lots of pre-curved files. So we finished the case. We wanted to place post and restore a case like this. We always check the occlusion. This patient was convinced that he needs an orthodontic treatment because his occlusion was out of control. So if you see the radiographs with a small time frame, we can have a very, very good healing. And also notice, please, despite of my lousy endo, the case is healing. Very large apex. I could not control the gutta percha properly, and I had some extrusion. During the removal of the gutta percha on tooth number 11 or tooth number 8, and during the obturation on tooth number 12 or tooth number 7. So, despite of the irritant of my gutta percha extruded, the body is healing. Why? Because we were able to diminish the virulence of the irritants of the root canal systems presented in this case. We didn't eliminate all the bacteria, but we were able to give conditions to the body to heal, and no surgery was needed here. When you plan complex cases like this, you need to think outside the box. We have a second upper premolar, right premolar, with a sinus tract, low sinus tract, very bad root canals, large metallic post. So before we touch this case, we need to take an impression, and we need to think about the restorative aspect of this tooth. An endodontist should provide solutions, not create more problems. So all the steps that I'm showing here, I do under the microscope. I trim the restoration, I take the impression. That's why we need a microscope with a very low mag and a very large optical field. So we remove the crown, we remove the post using ultrasonic. Immediately after removing the post, we saw pus coming out of the palatal root, and we were able to dry, and we were able to see a perforation, maybe a fracture. So we talked to the patient, and due to the fact of, there was a hopeless prognosis of this tooth, the tooth was extracted. So we did the temporary restoration, we planned for an implant, we did the extraction. We always take the image of the extraction socket to see the anatomy, and we document all the root, the perforation, the fracture, whatever it is involved. This is our sequence, this is how we work. So 3 months later, we finish the root canal on the first molar. 3 months later, we placed an implant. Then we did the healing cap and the prosthesis, finishing, and the 1 year recall. So the endodontist now needs to get involved more in dentistry, not only inside the root canal. Because if you don't know anything about implants, you cannot talk to your colleagues today. So you need to get involved in different things. You need to know different things to be able to communicate to others. So when I say about treating patients, not teeth, I can show cases like this, where I have a darkened tooth, number 11 or 8, or a little darker tooth, number 21 or number 9. But if you look at the radiographs, you're going to see that both of them, they have different problems. On the left side, I have a very immature tooth on a old patient. On the right side, I have a cervical resorption. So what to do with cases like this? What's the best treatment of option for patients like this? So you need to decide with your patient, and you need to know what to do and be able to do what's the best for your patient, what's the best for your patient, not for what you know what to do or what you are able to sell to the patient. So we were able to talk to the patient, and the patient on the left said, okay, doc, let's try to do the root canal. We have, the MTA, all the techniques and everything. That's a 7-year follow-up. And the patient on the right said, okay, doc, I think it's better for me to have an implant, so let's do the implant. And when you see the follow-up, both of them are satisfied, have the aesthetics maintained, functioning. So endodontists should provide solutions, not only paint white lines. So, in conclusion, we need to use technology in dentistry. And we are convinced that more technology, more knowledge will increase the chance of success. You should use your technology during the diagnosis and should use all the technology during your treatment. But please don't think that you only are going to be good if you have a CBCT, a microscope, and all the technology available. What I'm saying is that get the most out of your money. So get the technology that you can afford. But the most important factor, get the knowledge to use the technology that you have available. It doesn't matter if you buy expensive technologies, but if you don't know how to use it, you won't be able to take advantage, and you will not benefit your patients. You will only spend money. So changes are inevitable. And the only power in the universe able to prevent our needed changes are our own preconceptions. It doesn't matter if you buy a microscope, if you buy a ultrasonic unit, an apex locator, but if you never use it because you don't believe in change, you don't believe in the need, it's going to be worthless. On your right side, you'll see that this is me and my family representing an old-fashioned mind. So it doesn't matter if you have a microscope, but inside your brain, you are still thinking like a 18th century immigrant, because you never changed your perception about reality, because you have your preconceptions. So take a chance and change. I would like to thank everybody for listening to me. I would like to thank Rui and his team for his wonderful initiative. I would like to share with you my 3 passions: my family, my loved wife Thais, Gabriela, and Fabiana. My second passion is nature. I think we should take care of nature, we should embrace nature, and we should fight for preserving nature. In my work, I love what I do, and I try to get inside my office in the morning smiling and leave my office in the afternoon smiling. I like my assistant to be happy, and I like my patients to feel that I genuinely care for them. I would like to thank you so much for listening to me. I would like to thank Roy, his team, my colleagues that did a lot of work to put this meeting together. But think about this. We only want to share what we do. We only want to share what we believe. If this presentation is good to you, use. If it is not good, don't do anything. Nobody's trying to impose anything to you. We are just trying to show what we do and what we believe. You have my website here. If you want to talk to me, if you have any doubt, I will not sell any course to you. I have no commercial interest in any of the companies that I mentioned. I just mention the products that I use because I believe they work in my hands. If you have any doubts, any questions, if you want to share a case with me, please go to my website, find my email, and send to me. Thanks again for staying with me during this 1 hour and 20 minutes, and I hope this presentation was good for you. Bye.
Follow the page on Facebook, Instagram, YouTube and Telegram. Thank you, doctors.